everyone on the call today. I hope that the weather is as summery as you would want it to be, wherever you are. So you're welcome to the session 2 of the One NHS Finance and Proud2bOps Learning Webinar Series. And today we will be looking at NHS costing, which will be delivered by our amazing guest speaker, Stephen Lee, who will be looking at patient-level costing and the impact on enhancing patient care and services abilities of interest to operational managers, hence why this collaboration. So if you're meeting me for the first time, my name is Esther. I'm the program manager for Proud2bOps, working quite closely with Emma Challenge-Russell, who is the founder and chair of Proud2bOps, and she also doubles as the director of Horizons. So if you have a social media presence, if you're on X, for instance, or LinkedIn, please do give us a follow at Proud2bOps, or you can follow Emma Challenge-Russell, both on Twitter and LinkedIn. And if you do get to share the insight from today's session, please do tag us, as that will help recognize the work that Proud2bOps does, especially across health and care organizations. Thank you. So when we meet like this, we like to shine the light on our values and behaviors, because over the years, this has anchored the success of Proud2bOps. So when we meet like this, we like to ensure that the space is a safe space for everyone to air their opinion and air their voices. We also want to ensure that it's as inclusive as possible and that we treat each other with respect. That said, we also want this space to be where we generate ideas. So I would want us to be curious, to respectfully challenge, so that we can begin to lead and improve across our organizations. Again, we want us to have fun, so please do well to use the chat box. Let's engage within the chat box. Tell us who you are, tell us your name and the city that you're joining us from. And as the session go on, please do engage using the chat box, or raise your hands, and I believe Steve will be able to respond to your questions as well. So this just to shine the light on the successes that we have made as Proud2bOps over the years. So Proud2bOps started within a region, but now we have continued to spread the scale across all the regions in England, and we're looking at spreading towards other countries in the United Kingdom. And we right now pride ourselves with over 1,500 members. So safe to say thank you to every Proud2bOps members for continuously shining the light on Proud2bOps and spreading the work that we do. So this is just a quick summary of the events that we have coming up. This is the second session of the One Finance and Proud2bOps webinar series. That means that the third session with the expert will hold on the 8th of July. Team's invite has been sent across. And if you haven't gotten it yet, please do let us know, and we'll forward one to you. Now, we've had 3 sessions of the Proud2bOps DOS Data and Information series. And the last session is on the 11th of July. So we know that this 4th session will be as amazing as the past 3 sessions. So please do well to attend. And within the week, we sent you the invite for the NHS Impact session with Proud2bOps. If you haven't received that, please do let us know. But it's going to be like an insightful session that you would love to attend. Again, in October, we're going to be having an in-person congress in Manchester, and it's also going to double as the Proud2bOps award session or award time as well. So the award categories will be sent to you in due course. So please do well to nominate and would vote to who receives the award or not. So this is the end of my slide. Thank you very much for your time, and I'll hand over to Steve.
Lovely, that's great. Thanks very much. I'm not too sure about the exciting delivery of the content today, but I will do my very best for you. It's a subject that I'm really, really passionate about, so hopefully we will get a little bit of excitement in there, and we'll be able to give you some really useful information to take away. And so if you just bear with me for 2 seconds, I will share my slides. Okay, so hopefully you'll be able to see those okay. So just a little bit of background. So my name is Stephen Lee. I'm one of the heads of finance at the University Hospitals of Leicester. I've worked in NHS finance for far too long. I think it's around about 22, 23 years. Started in financial management, did a little bit of a stint over in financial accounts, and then came into the costing arena around about 10 or so years ago. And it's kept me here ever since. I think it adds huge value to organizations. I think there's massive opportunities that can be realized using costing data. And it is one of the genuinely the most exciting, if you can get exciting, functions in finance, I think. So hopefully, as I say, you'll take a few things away from today and be able to go back and start asking lots of questions within your organization, and start to add some value. So just a little bit about what we're going to cover today. Excuse me. For those of you that aren't familiar with costing, what is it? Why is it important to us? How we can start to understand the resources that are used across a patient journey and the system that we use to track that. And then most importantly, for you guys, how we can use that to improve the care that we deliver to our patients and improve the efficiency and productivity of our organisations. I'll pause after each of the sections that we've got. So if you've got any questions, feel free to pop your hand up, pop a question in the chat. I've got that up as well, so hopefully we'll pick that up as we go along, and I will do my very best to answer anything that you ask. We can take questions at the end as well, if we've got time. So what is costing? So the boring side of it, and the kind of technical definition is that it is the quantification in financial terms of the value of resources that you consume in your organisations whilst carrying out a particular activity or producing a certain output. For us in the NHS, it's all about what does it cost to deliver the clinical services that we provide, and in particular, as we go into some of the detail later on, how much does it cost to treat each of the individual patients that come through our doors? In order to do that, every NHS organisation is mandated to use a PLIC system, so patient level information and costing system, and there's a national programme of work to collect the costs for that, as well as the kind of local information that's produced. We'll talk more about each of those elements as we go through the presentation. So a lot of you out there might be budget holders within your organisations, manage a host of budgets. Some people may be familiar with costing, and others might not. So we always like to kind of illustrate what the key differences are between those traditional financial management or budget reports that you receive, and the information that's produced in PLICs, or aggregated version of PLICs that you might hear referred to as service line reporting or anything like that. So there's two key differences. So PLICs information or costing information doesn't tend to look at budgets, so we will not compare your performance against a plan. We will strictly look at the cost of delivering your services, and some organisations will compare that to the income that you generate. We also look at a whole cost of running those services, or treating those patients, not just the direct cost that you might hold within the cost centres that you manage. So we allocate costs from support services like theatres, pharmacy, pathology, radiology, and then all of the overheads of the trust, to those frontline clinical areas to create a true picture of the cost of running that service and compare that to the income. So that's a little bit about the difference. And there's just a really quick illustration of that as well to give you a bit of a visual feel and how that might play through to the values that come out of those two different approaches. So this was an example from a while ago within our vascular surgery service. The top element of the chart that we see here is what you might see in kind of traditional financial management reporting. So you'll have a plan for the expenditure and the income. You'll have your actual values that you've delivered. So in this instance, we've delivered a deficit against our expenditure plan of £500,000, but that's offset by an overperformance of income against the income target. So you can see traditional financial management reporting within our services at UHL would have shown that vascular surgery had an overall surplus of £0.3 million when you compare the direct costs of running that service and its variance to plan against the income that's generated through that activity compared to plan. During the costing process, we will take each of these different elements, and there are probably more than this, but it's just an illustration. So the anaesthetic support that's required when we're in surgery, the theatre's cost, the imaging, the pathology, the therapies, any critical care, those kind of things, put that into the pot. And we see that the actual cost of delivering that service goes up from £5 million worth of direct costs for things like the medical staff and wards, up to a total cost of £9.2 million. The income for that service goes up ever so slightly because we apportion income from our corporate services and trust-wide elements. And what we actually see is what was a £0.3 million variance to plan for that service to the good actually turns in, when you look at a fully absorbed cost and income position, as a loss of £1.3 million. So you might go from saying, I'm performing really well, I'm hitting my targets, but actually, when you compare the overall position that's generated for the trust, it's not such a great outlook. And it's really important for us to highlight those services that are kind of outspending compared to the income that they receive, because as we all know, the financial position of the NHS as a whole is really stretched at the moment. And so it's just a different view and a different lens. So why do we cost? I've just touched on it. I'm sure all of you will know this. Oh, we've got a quick question actually. I can see a hand up. I'll pause at that point and just see if we can address that question from Julie.
Yeah, in regards to the previous slide, you just come off. You know, when we see, I think it's called EBITA, I think it's called, in terms, is that the just the plan versus the variance cost, or is that the true? You know, we know I'm talking to you. I'm a UHL member staff. So when we have our finance slides, there'll be something that's called the EBITA. Is that the true full cost allocated position, or is it just the income, or is it just the plan versus variance surplus? So how do I know whether my services are making a true surplus or not?
Okay, so I think the report that you're talking about specifically, I think it's an EBITDA one. So it's I can't remember the technical term, earnings before.
Something like that.
Yeah. So that is a fully absorbed cost. So that will come out of the PLIC system that we'll talk about a little bit more later down the line. So that will show the full income that you generate as a service or a clinical management group, and it will show the full cost of
that is my true, whether I'm making a true surplus or deficit then. Yeah, thanks.
Absolutely.
Thank you.
Yeah.
Thank you.
No problem at all. So why do we do it? As I say, most of you won't need me to tell you this, or you won't need to Google it. But if you Google financial pressures in the NHS, you'll get no end of articles, studies, documentation that tells you about how tight cash is within the organisations that comprise the NHS, how the growing age of the population will be putting more and more pressures on the resources that we've got, and the cash that we're provided from NHS is pretty much flat cash. So to give you a little bit of context, there's been a recent report from the NHS Confederation talking about the state of NHS finances for the financial year that we've just moved into. So the NHS as a whole has been set a 2.2% efficiency target, which is pretty big. But when you talk to each organisation across the NHS, it's actually much bigger than that. So the average efficiency and productivity savings that organisations are being asked to make this year is more like 6%. There is some variation between organisations, but a lot of that is around the national ask of 2.2%, but added on to that any other pressures within your organisations and carry forward of efficiency targets are set in previous years that we've not been able to meet recurrently. So it's a huge challenge. And to put that into context, a trust like UHL with a £1.5 billion there or thereabouts turnover, 2.2% efficiency equates to a £33 million target. And if you were to convert that to the average kind of rate for a band 5 nurse, that's 660 nurses. At 6%, it's a £90 million target, or the equivalent of £1,800 whole-time equivalent nurses, which is huge. And we're never going to take 1,800 nurses out of our establishments, and really the only way to kind of meet that target is to make significant changes to the way we undertake our activities. And to do that, I think we need a good understanding of what resources we use as an organisation, where we use them, where there is clinical variation, and where opportunities might lie within specific services or specific cohorts of patients and treatments. So I think costing can play a huge part, hopefully, in the identification of that £90 million. And for context, I think it is 92 million at UHL for this year. That's our target. So they're not just kind of numbers plucked out of the air. That is very real across the NHS. So I just wanted to talk a little bit about the detail behind patient level information and costing systems, or PLICs, kind of how we get to this view that we hope will tell you about how you might be able to transform your services or identify those services that are in need of a bit more support or that might be causing us pressures across the organisation. We've covered what it stands for in terms of PLICs, and service line reporting is often referred to as an aggregated version of that patient level data, but at a specialty or service line level. So how do we do it? In essence, what we want to do is to try and trace all of the resources that have been consumed by a patient from the minute they come through our front door to the minute we hopefully send them back home or on to care elsewhere within the sector. Now we do that by gathering as much activity information as we can about what has happened to that patient and where those things happened, what resources have been used, how long those resources were used for. And that can be anything from staffing time to the consumables that have been used to the diagnostics that we've performed, all sorts of different bits and bobs. And we trace those, and we'll talk a little bit more about then what we do with that once they've been kind of recorded and traced, and how we kind of turn that into a cost. But by doing that, and at that really granular level, we can start off with a position that starts to show you about the profitability of your services, and we can drill into that at a range of different details, a range of different levels in terms of how that's been recorded against those patients. So whether we want to analyse it at a specialty level, a consultant level, a healthcare resource group, or procedures, diagnosis, all sorts of different ways we can kind of cut that data because it's done at that really granular patient level and resource level. So it's really, really useful because it gives us that profitability analysis, and it combines both cost and activity, which doesn't tend to happen in too many other forums or methodologies. It can highlight clinical variation, and it can allow us to do some really detailed pathway analysis. We'll talk about some of the other benefits later on, but it can also help to support with kind of counting and coding changes across services and clinical management groups. So before we talk more about the kind of how and what goes through the sausage machine, there's a few key considerations that we need to make. So the first one is, what data do we hold as an organisation about how our patients move through the system? The more data that we can get about what happens to our patients, the more accurate we can kind of make the outputs that we produce. We then need to consider any gaps in that information. So if we know there are things that happen to our patients that we don't physically record on an electronic system, is there any other supporting information, or can we use local knowledge or assumptions to bridge those gaps? And then the third part of it is whether the structure of our existing financial information that goes through the general ledger matches the structure of that activity data. So if we talk about a really quick example, does the way that we record our ward stays for our patients, which can be a big driver of how much money we spend, does that recording of those ward stays correlate to the same coding that we have in our general ledger about the costs for those wards and that kind of thing? So there's three kind of things that we work through as we're starting to build some of the costs and as we improve the way that we allocate those costs. And it's all about how that activity data links back to the general ledger and what other assumptions we might need to make. Not a particularly detailed diagram of how we do it, but hopefully it should give you a bit of an illustration. So the first part is that we bring in our core patient activity information. So this has got a few elements on here, and this will vary across organisations depending on your type of organisation and what services you provide. But our biggest ones at UHL are consultant episode information, which is basically your day case, elective inpatient and non-elective or emergency activity, your outpatient information, A&E attendances, renal dialysis, and then we have a few others like radiotherapy and things that don't get recorded in those core data sets. So it's basically what patients come through our doors. We then pull in supplementary information. This is just a snapshot of the feeders that we get. So the big ones are ward stay information. So how long does every patient stay on a ward for? What ward is it? Sometimes it's about the level of care they receive on those wards. Information about theatre operations. So how long are they in theatres for? Which people were in that theatre when that person was being operated on, the number of recovery minutes, minutes under anaesthesia, all sorts of bits and bobs like that. Then we move into diagnostics around pathology, imaging, what drugs people have been issued, what therapy contacts they might have, and whether there are things like high-cost devices. So we bring in activity sources that tell us all of these different things about the way these patients were treated. As I say, that's just a small snapshot. One of the biggest parts of the kind of hog churning that the system does is the linking of this cost driver information and the information about what resources are being consumed with those initial patient activities. So we have something to link up based on the patient identifiers that are recorded in systems and the date timestamps that those things happen. So if a particular patient's had a number of episodes across the year, we'll be looking for their ward stays and their theatre minutes that relate to those specific attendances, and we build those relationships between the two. The third part of that cogwheel is then the kind of ledger costs that come into the system, and we link those ledger costs and the costs that are on each of our cost centres in the general ledger back to those cost drivers. So if we've got a cost centre for Ward 22 at the Leicester Royal Infirmary, we'll look at that £2 million worth of cost, and we'll link that to all the patients that have stayed on that ward and the amount of time that they've been on there and that kind of thing. So we'll divvy up £2 million based on the patient stays for that. And there's a whole series of rules that are built within the system that tell us then how those kind of costs and activities link together. So just to give you a really quick illustration, these are the kind of things that might go into a particular patient pathway and the types of costs that we'll be assigning. I don't think there's anything on there that's particularly strange for anybody, and you'll all be familiar with all of those different elements of cost. But you might only be responsible for managing certain parts of those costs, but all of those will be involved in the cost of providing that patient care. So before I go on to what some of the outputs can look like, has anybody got any questions about the kind of PLIX process and that kind of thing? Yep.
It's Christy. Hi, Steve.
Hi, Christy.
Apologies if I'm jumping the gun and if this is coming later. Obviously, as ops, a lot of those efficiency targets that you mentioned comes down to us to sort of find ways to sort of mitigate, etc. But just the intelligence behind it. Obviously, you've been doing this for a long time. What's the sort of quick wins, if there are any, in terms of from your costing expertise? Are there key highlights of waste? Well, if you just looked at those 2-3 things, there might not be any, in which case that's fine. But if there is anything that we could straight away go to, because obviously it's not just the budgets that we're working in, it's a much broader piece, isn't it? So that holistic picture, sometimes as ops, we don't have it. So
yeah, it's a great question. I think we'll try and come back to that later on. So we've got some real world examples of some of the work that we've done within our organisation and some of the ways that we look at our data moving forwards. So that might give you a flavour about where you can go. I think when we talk to specialties across our organisation, there's a few key themes, which are the ones that we'll cover later on, but there do tend to be a few specifics and a few things that do come up over and over again when we look at those when we look at those services. And I'll talk to you a little bit about some of the service reviews that we're planning moving forwards. But yes, absolutely, we'll try and share as much as we can as we move through the presentation.
Okay.
See where we get to. Cool. Is there another question from Antonia?
Hi, I was just wondering if this kind of analysis is used across trusts as well. So kind of to see how one patient's moving throughout the system and where the costs are strongest. Is that something that's currently being done or would work?
It's an interesting one. So we'll talk a little bit about benchmarking later on. So there is a national collection of some of this data, and we're able to compare ourselves to other organisations and to national averages. I think a lot of organisations are starting to move along a journey of how our resources are used treating the same patients across different organisations. It's not something that we've done an awful lot at Leicester, and I think there are a few governance issues on some of those bits, but yeah, we can certainly try and pick that up as we move later on through the presentation as well.
Okay, thank you.
No worries. I can't see any other hands up. So there's here at Leicester, we have a specific tool which a lot of acute providers use, and they give us some dashboards that allows us to pull some of the data out of the system, and that can range massively from a high level summary that you can see here, and we'll talk through in a second, right down to day by day costing of specific patients, and we're starting to build on that data that's available in those dashboards and look at how else we can present that data to provide the most useful and easily accessible information to our service users. So in this example, it's really straightforward. There's a specific specialty that we've selected in our dashboards. It will tell us the overall position for that particular service. I think this might have been cardiac surgery or cardiology, I can't quite remember. And at the point of time that we ran this, you can see a high-level snapshot that says we were spending £14 million and only generating just under £10 million worth of income, so a huge loss. It can also highlight some of the particular activities that you undertake that perform well or perform poorly. So you can see of that £4 million loss, £1.8 million of that is being driven by just 5 HRG codes that we would then want to kind of get under the skin of and start to investigate a little bit more. And there are not many HRGs that are generating as a surplus. So that's at a very high level what some of the outputs can look like, contrasted with an example of a particular patient whose entire length of stay we can see in chart form that tells us about when that patient received certain elements of care and when they were using different resources. And we can see how that pans out over time. And this can be really, really useful to clinicians and managers to understand the spread of resources within patient journeys, look at whether they can change or modify the pathways to improve this. We've seen some examples where we have had some really intensive resource at the start of a stay in cardiology with then very, very minimal resources being used whilst they were waiting for a theatre slot in cardiac surgery. And then you see really high costs and then it kind of tails off again. And that led those services to work better together to discharge patients between when they'd been identified as requiring surgery and if they were fit to go home before then being readmitted. And it frees up those beds for another cohort of patients and those kind of things. And that visual representation of when and where you're using those resources can really help with those kind of things. So that's two examples of how the data can look, and we'll talk about some of the in-between bits later on when we're talking about using the data. And this is something else that we've started to produce in Leicester as well. So rather than looking at a snapshot of what a particular service costs or what a particular patient costs, how does that vary over time and what's your direction of travel in terms of your productivity or efficiency. So this shows a representation of the cost of providing services at UHL divided by the number of activity units we're producing. So it's a productivity equation. The lower your cost per weighted unit of activity, the better you're performing. And as we can see on this, during 2021, the height of the pandemic, the cost of producing each unit of output within UHL went through the roof. We've slowly started to recover towards the back end of 22-23, and then the costs have crept back up again, mainly down to things like industrial action and some of the additional staffing we've put into the organisation. But we can drill into this at any of those levels that we produce our Plex data. So we can look at this by specialty, points delivery, and that kind of thing. So lots of data that's produced and lots of different ways that you can view that and see that. I think I saw a hand go up, but oh yeah, there we go.
You did, and then I put it down again because I didn't know if you'd come to me. Yeah, that previous slide deck where you were able to look at the costs, for example, is that only available to finance staff, or is that available at operational level? I'm deputy head of ops. I've never seen anything like this before, or even had it displayed in when we have our discussions with finance. So I'm assuming this is a finance level.
So we make these dashboards available to anybody that would like access to them. There are a number of clinicians and ops managers that have access to this in Leicester, along with transformation leads and I think the business intelligence specialists as well. So we're trying more and more to get this data out there. So we used to have really good levels of engagement. The pandemic hit, those levels of engagement dropped off quite significantly. and we're starting to try and build that back up and get this data out there to as many people as possible. So if you'd like to see it, you'd like a demo, have a chat with your finance colleagues, come and find me. And we
Do I
can
approach the head of the group, the head of finance, and in terms of the CMG then to get access to that?
So it would be my team that would provide access
So I'd
to
come
this.
to you then, shall I, in the
So come
first
to me.
instance? All right, we'll do.
Yeah, and then we
Thank you.
like to work in conjunction with the finance teams where possible,
Yeah.
and keep them engaged.
I'm just thinking in terms of the SIP and the huge savings. I think a real granular understanding of the cost of the service would be quite helpful.
I
Thank you.
sincerely hope so, yes. And we're trying to get some of this data into our more regular reporting as well. So hopefully over time you'll see the development of some of the reports that we can produce making their way into things like performance review meetings. And what we'd really like to do is get onto CMG board agendas and get the heads of finance to present some of this data there.
Okay, I'll contact you then. Thank you, Steve.
No problem at all. Where are we for time? We're looking good. So some use cases for the data then. So we've spoken a little bit about some of them, but I'll try and go into some of them in a little bit more detail. So I think for me, one of the fundamental things that costing data can give you, and in particular Plix, it can help to give our key decision makers a better understanding of their economic drivers. So where are we spending our money? How are we spending our money? And how are we using those resources? And how does that impact on the overall performance of the organisation? I think traditional financial management is good for stating what those costs are and how you're performing against a plan, but it doesn't really tell you anything about the drivers of those costs. So why are you spending more money? And what are the key things that are influencing that? So getting a good understanding of those is the first thing. The next two on here are kind of interlinked. So benchmarking, we produce our data to a set of national standards. So NHS England prescribe the way that you should cost. As a minimum, you can go beyond that if you have better data and better methodologies. You just have to document it. But it does mean that data should be comparable across organisations. So NHSE publish data to things like the Model Hospital, and there's a national Plix dashboard that can be accessed. So we could, as an example, look at the cost of performing a hip replacement here in Leicester and compare that to our peers in Nottingham, Birmingham, wherever it may be, and say, how do those costs differ? And how do the cost components within that differ as well? So we don't just say we cost £3,000 and it costs £2,500 at Nottingham. We must be doing something terribly wrong. We can see the granular information that tells us whether that's a higher ward cost because our length of stay is higher, or are we spending more in theatres, or are we requesting more diagnostics, and those kind of things. So there's some really, really useful national data out there, and it allows us to benchmark across organisations. The identify difference in practice is very much along those same lines as the benchmarking, but at a local level, we can see even more information. So within that Plix data and that patient level information, we can go right down to the level of detail that would tell us the types of drugs that are being prescribed to certain patients and the cost of those. We can compare that from one clinician that treats the same kind of cohort of patients as another one and see whether their drug choices impact on the overall cost of care for that patient. We can look at the number of diagnostics they're requesting. We've done work where we look at whether people are repeat testing on the same patients and things like that. You can look at whether the choice of prosthesis might have an impact on the cost and the outcomes for those patients as well. So you can get some really, really granular level detail, and we can compare the treatments that are provided from clinician to clinician over the same groups of patients. At this point, I always take a quick pause and say that we always encourage people to use this information as a starting point for a conversation and not for it to be a reason to beat a clinician with a big stick. So what this doesn't do, it will tell you whether for that hip procedure, one consultant is more expensive than the other. What it won't do is say, what are the outcomes for that patient? Does the consultant that costs more have fewer readmission rates? Do they have better patient satisfaction? Do we do fewer follow-ups on their outpatient pathway? And is the overall journey for that patient a better journey for the patients and for the resources that we consume as an organisation? So we'll always encourage people to use this as a conversation starting point, but to take into consideration things like outcomes and other performance measures, as I think that's really, really important. As we say, it may on the face of things look to be the most expensive way of treating a patient, but it could be the best way to treat them and the better thing for the wider health economy. So yeah, just a plea that if you do get access to that data, whatever trust you're in, always consider those things. So the benchmarking, the identifying differences in practice, I think some of that comes back to that question from earlier on about some of the benefits that we can derive. There are often in every service that we go to examples of clinical variation where we've been able to say, if you standardise this practice, you will be able to save X amount of pounds, and that may also have an impact on patient care and quality as well. So I don't think I've been to a service where we've not seen a difference in practice. Is it always easy to implement that standardisation? Probably not, but it's certainly something that we should look towards doing. The next one on the list is informing tariff setting. So I mentioned that all of this data goes off to NHS from every organisation, and that is used to help set tariffs for future years, or has been in the past. So that's one element. The more accurate we get this data, the better the tariffs will be set moving forwards. But we can also use some of this to help negotiate local prices as well. So where there's not a national tariff, or you've got a specialist service and you want to negotiate prices with your commissioners, this can be a really, really powerful source of information. I know that before we had good clicks data, we negotiated price with our commissioners, that we didn't actually know whether that covered our costs or not. Now we can say whether those prices that we agree locally cover the costs of delivering those services or not, and allow that conversation to progress. I've not put it on here, but it can also be really, really useful to check that the income that you are receiving is appropriate and your clinical coding is appropriate. So when we start to look at whether you're profitable or not, and we compare the income that you generate for each patient to the cost of delivering that care, often if your costs exceed the income that you generate, there may be a reason around productivity or efficiency that you can improve on. Sometimes there's not. And that raises the question as to whether we're appropriately recording our patient activity, generating the right healthcare resource groups, and getting paid appropriately for that. So we've used some of this data in the past to identify areas where we're making losses. We know that we're reasonably productive when we compare it to our peers, in terms of the cost of delivering that. So then we've gone and we've looked at the clinical coding to tell us about whether we're recording all of the diagnoses and procedures that we should be to generate that right HRG. One of the examples from a number of years ago, I think it was highlighted through trauma and orthopedics. Our tariff values were really low, and we discovered that we weren't recording therapies as a thing that had been kind of performed with our patients, and that actually lifted our overall payment for that service by £1 million or £2 million, which was quite significant for not recording one code against a lot of the patients that receive that element of care. And that was all highlighted through the PLIX data. So it can be really, really useful for that kind of thing as well. We've used it across a number of business cases here in Leicester. So often ops teams, clinicians will kind of know what the expected changes are to patient pathways and the extra resources that we'll need. They're not always able to illustrate the other benefits from a financial point of view. So we might know that a particular intervention that we put another couple of nurses in for might reduce length of stay by a couple of days, but you're not able to quantify that saving in terms of pounds and pence, and if you can't quantify the benefits of that thing, often your business cases won't be approved. Costing data can help in all sorts of ways, whether that's those really simple costs around length of stay improvements, or converting from an elective to a day case pathway, whatever it might be. We can usually model something for you. So we've got examples later on in the presentation about how we've done that for some things in our imaging and cardiology services as well. And then the last thing I've popped on there in terms of how we can use it within the organisation is to track your performance over time. I gave a brief intro on our cost per wow slide, and I think there's a couple more further forward as well. So a few different ways that you can use this data, hopefully all very useful. Now, some real life examples. So this one was developing a business case with our imaging service. This was a good few years ago. And they came to us and said, we want to introduce some new diagnostics that are going to cost us £700 for every patient that we do those diagnostics on, which the commissioners don't want to fund us for, but we think are really, really good for the patient. So these diagnostics, the heart flow FFRCTs, can improve the diagnosis of patients with CAD, and reduce the number of non-invasive tests and invasive angiography. So through some research, I think they were saying that 30 or 40% of people that would have this enhanced scan, it was deemed that only 30 to 40% of those people would have required invasive angiography that would have just been given it anyway previously. So better for patient care, freeing up some of our resources, but they didn't really know how to quantify that. So we talked to them about how we could model those pathways and use the existing information in our PLIX system to kind of cost that and work that through. So for the 130 patients that went through this pathway, we had an average cost of about £6,300. When we modelled that and gave everybody an FFRCT and took that 30% of patients that would only need the catheter intervention, the cost of those patients went up to nearly £7,000 because of the extra £700 a patient. But those patients that didn't go through that pathway would have a treatment in a different way. I think it was a drug treatment. Their pathway cost was only £2,000. So even though everybody was having an extra £700 worth of costs that the commissioners didn't want to pay for, overall we'd have gone from a cost of treating those 131 patients of £800,000 to less than £500,000. So a saving of around about £300,000. So a really good case for using costing data and taking that forwards. I can see a hand up. I can't see who it is. So if you want to jump in, feel free.
And I'm pathology centre manager at Shrewsbury and Telford. Just on this, and I appreciate there's a saving to the public purse, and that's a good thing. If I was at the other side of that same coin, you've just removed income from a different service. because the commissioners are not having to pay it out, which is a good thing for the NHS as a whole and for the trust and public and all that sort of thing. But that individual service, how do you account for that in their income targets, in their budget? Because, you know, every action has a reaction, and the reaction to is saving to radiology, but a reduction of income to wherever it was, cardiology or whoever's getting the
Yeah. I mean, it's a very good question. I think in this instance, there was also a saving to cardiology, or I say a saving. It probably wasn't a saving, but they were able to reutilize a lot of their resources to reduce backlogs and waiting lists. So because a lot of those patients weren't going back through our catheter suites, the amount of resource that was required in those catheter suites could be freed up to treat patients that were on the waiting list for other things. So there is a direct benefit to both services in this instance. But I think when we've looked at some of these things before in terms of business cases at the organisation, sometimes I think some of those considerations have been made, and when we've moved through into new year budget setting, those things have been reflected. So the income target might be lowered for the following year. So they've not got to achieve that same level, and that potentially they won't need to spend as much. But it all flows through, and we try and I say try, it's the key word there. Where there are savings to organisations, we try and recognise that impact across the whole of the organisation, whether that's through potential gain share arrangements and things like that. So it's tricky. I don't think we ever get it 100% right, but we do try and account for a lot of those things, and particularly when we move into subsequent financial years, when we're able to restate budgets and things like that, we'll try and pick those kind of things up. I don't know how well that answers your question.
That did actually, particularly that last point about it's reflected in the following year's budget, which I suppose is what you'd hope. Ultimately, it's better for the patient and it saves public money, so it's got to be a good thing. But from a selfish perspective, there's a budget holder saying, hold on, you're taking a chunk of money out of my budget. But if it's reflected and accepted the next year when it's reset, then that's how it's done. That's great. Thank you.
No problem. As I say, I can't guarantee that it happens 100% of the time, but where the things have been raised as part of the budget setting process, then we try and flow those things through. So, and I think we are getting better at it. So that was an example of using it for business cases. These are just a couple of illustrations around looking at clinical variation within some of our services. So again, some of these slides are a little bit old, but they should give you a flavour of how easy it is to pick up on some of that variation. So these set of charts and things were for one of our hip procedures. And you can see from the chart on the left-hand side, the income that these are different clinicians down the left-hand side that have been blurred out to save embarrassment. The income is all reasonably static, as you'd expect, because they're all being coded as the same HRG, but there's quite significant variation in the cost of providing that care, and the blue lines to the left is the amount of money we're losing against cases for each of those consultants. So when we started to drill into some of this data, we started to break that down into the different big drivers of cost. And the same consultants that are at the top of this list generating the biggest losses were those consultants who'd got the highest theatre cost and the highest or the longest amount of time for their theatre operations, and they were the same consultants that had the longer lengths of stay and subsequent highest average cost. So that information was shared with the service to see whether they could unpick why that particular consultant was both taking longer to treat their patients in theatre and keeping them in the beds longer. As I say, change in practice is more difficult, but I think when we can start to highlight some of these things, it illustrates the amount of opportunity that there is out there, and it's really, really easy to get into some of that data. I've reiterated on there, it's really important to consider other factors like clinical outcomes and patient satisfaction. Again, because it might be that that patient takes longer, or that consultant takes longer in theatres, but actually his readmission rates are a lot lower, and he has more successful operations. We also had an example, there's lots of numbers on here, where we had brought online a Vanguard theatre at our organisation to try and get our waiting list down post-pandemic. What we noticed when that information was going through the PLIX system was that our patients that were going through that Vanguard theatre were coming out way more expensive than those who are going through our established permanent theatres. So the table down here, you can see some of the activity that we were undertaking. The cost of that activity significantly outweighed the cost that were in our standard theatres. In some of these pain management cases, over 3 times the value. What we then started to do based on the underpinning data for that was to look at how many minutes were available through those theatres based on the scheduling, how many minutes were used, and what the utilisation of those theatres were. And you can see that our second Vanguard theatre had utilisation rates as low as 20–30%, and that idle time was really, really high. So we were paying a premium resource for these temporary theatres, and they were being underutilised, which was driving a massive kind of increase in the cost of treating our patients. And we kind of looked at what the cost of that idle time was, and just over a 3-month period, it was almost costing us £1 million for unused time in those theatres. So as it happens, those Vanguard theatres, I believe, were scrapped, and we're no longer using them anymore. But without that kind of data, linking it back to patients and seeing the variation between using one resource and another, I'm not sure whether all of those decisions would be made. And then the third one, was using some of this data to track productivity. This goes back to that the SPC chart that I showed you earlier. So we were challenged to create a model that took NHSE's implied productivity metric, which basically says how much activity you do and how much cost you have, what's one divided by the other, and is that moving over time. At a trust level, so we're asked to combine something like that alongside the model hospital metrics to calculate something that would show us how we're changing over time, but at a specialty and a wider clinical management group point of view. So we did a few things. So we created a common activity unit, like what they do in the model hospital with their WOWs. We took our PLIX costs, which were then aggregated at a specialty and points delivery level, and we adjusted that for inflation and known changes in costing methodologies, and we plotted that over an SPC chart to get the chart that I shared with you earlier. So it gives us a really good indication of how we're performing over time, and whether when we drill into this, whether there are certain services that are heading in the wrong direction. So we've identified a number of priority services within UHL now that have all got a higher cost per weighted activity unit now than what they had pre-pandemic, and we're starting to do some in-depth reviews with those services. I'll pause there. I think there's another hand up.
Lee, can you just say, sorry, what's a WOW?
So it's a weighted activity unit. So in the model hospital, if you've not seen that, NHS have done is try to convert all of the activity that you do as an organisation to the equivalent of one elective inpatient stay. So if you've got a different mix of kind of inpatient to outpatient activity at your organisation compared to another, they try and convert all of your activities to the same kind of equivalent, so you can compare whether your output is higher or lower than another organisation, or whether your output changes over time if that mix of activity changes.
Okay.
So basically what they do is take a national average cost of delivering each activity, divide that by £3,500, times it by your amount of activity and divide it by £3,500, which is the average price for an elective inpatient, and then they come up with this common unit of activity.
Okay.
If you've got access to the model hospital, it tells you more about the way they undertake that calculation. If you've not got access to the model hospital, I would encourage you to jump on there. If you just Google NHS model hospital, you can register and get all sorts of useful information out of that.
Okay. Thank you.
No problem at all. So one of the things that we've then started to do based on questions that we've had from our services after seeing this information is what's driving that change. So what we've also started to do is convert that change into an opportunity value. So we take what your cost per weighted activity unit was pre-pandemic, compare that to the current cost per weighted activity unit, and multiply that by your output. So within general surgery, as an example here, we can see that our cost per weighted activity unit has gone up by £1,000 over that 3 or 4 year period. We undertake 5,000 weighted activity units in that service, so that's the equivalent of there being almost a £6,000 opportunity if we were able to get back to pre-pandemic levels. We then break that opportunity down into the different cost drivers that are flowing through the PLIC system. So we can see that this is driven by increases in medical staff costs, ward costs and theatres within general surgery, which are probably what you'd expect. But we've also got things in, say, neurology, where we can see therapies coming up as a key driver because we've increased the amount of physio support to that service and things like that. So we're starting to try and get under the skin of those movements a lot more and understand what's driving it. What we're seeing in a lot of areas is investment in areas for things like safety and quality improvements that don't necessarily increase your output. And a lot of those things are driving some of those costs, but much more work to do. So there's some examples of how we've used it at UHL. So how can you be involved, and how would I like you to all be involved? Well, for me and my team, we're quite well resourced, I think, for a costing team. So we currently operate with 5 people in my team. But when you consider that we've got something like 150 different service lines within our organisation and spend of £1.5 billion, that's a lot for us to look at, to understand those services, to understand what data is available and engage with our clinicians. So ops managers, service managers, anybody that's interested in driving improvement, we'd really, really like your support to help us kind of look at those three circles that we see there. You hopefully will have a really good understanding of the specific elements of the care that we provide. You'll have some influence on how we can change that care and how that care meets the needs of our patients and our organisation. So with your support, we can try and improve the quality of the data that we're flowing through here, but also kind of harness your thoughts around how we can make improvements, support decision making, and that kind of thing. when we come out and talk to services, whether that's clinicians or managers, there are always frustrations about blockers within the service in terms of trying to drive improvements. One of the things that we can probably do is help to quantify some of those issues financially to then maybe unlock some of the changes that you might want to make. Oops, sorry, keeps. Now, so in terms of getting some clinical engagements, and not just clinical, but managerial as well, we in finance that produce this data are by no means experts in caring for our patients. In most cases, you won't be experts in NHS finance, but if we can work together to improve the quality of the costing outputs and use them, we can improve the quality of care and the financial sustainability of our organisations. So the people within your services, I think, hold the key to understanding how we consume our resources. You know what's recorded, and you usually have a feel for where those processes can be improved. And we can help to, as I say, evidence or disprove hypotheses about a service or a treatment or the way we do things. We can highlight new areas of opportunity through benchmarking and analysis. And most kind of the wider picture of it is that we pull together a lot of information that isn't usually all seen in one place, and it helps to kind of link those things and inform things in a much more holistic way. So I guess just a few tips for those people that do want to know more, learn more. One of the things that we've had fed back to us from the people that we've worked with is that almost in every instance, it does take your time and resource to get involved, to do some of the work, but the benefits do outweigh that initial kind of investment that you need in terms of your time. And it can really unlock some powerful things. So don't be put off if you think you've not got the time. It can really help to unlock things. So we'd encourage you to take that time. Engage with your costing and finance colleagues. There is a wealth of information out there. Hopefully we've kind of piqued your interest in that a little bit. So go and talk to your finance colleagues about what you hold within your organisation. It might not be perfect, but it's usually good enough to help get some things over the line and to point you in the right direction of where you could be looking. We always find that getting traction with clinicians, if you focus on what's important to them, it's a much easier journey. So try and work with them as closely as you can. And lastly, use your local networks and some of the organisations like the HFMA, One NHS Finance, Proud2bOps. I should have updated the slides for that, because a lot of the time, if you're looking at something, somebody else has probably already looked at it as well and is facing those same issues, or has taken something forward and might be able to give you some advice and support. And most people that I've spoken to are all willing to help and support on those things. So I think that's about it from me. There are some resources out there from the HFMA and One NHS Finance around costing, the benefits that you can get from it, and also some additional training. There are also a wealth of One NHS Finance value makers and FACE representatives. So FACE is finance and clinical educators, who will all know about this. Hopefully you've got some in your organisation and they can help to start realising some of those benefits. So I'd encourage you to go and have those conversations. I think that's about it in terms of the presentation. So I guess it's just, are there any other questions? Have I answered those questions from previously as well? Deadly silence. I was just having a quick look in the chat to see a few things about WOWs and workstation on wheels, but
Steve, I think Lena wants to come in.
all right. Hi, Lena.
Hi, thank you so much, Steve. I followed what I could. Just wanted to ask your offer of help, which is much appreciated. Is that open just to colleagues in Leicester, or are you working nationally, or?
So I am more than happy to have conversations with people, whether I can help you with specific local issues. I'm more than happy to have a conversation and talk about that. So if there's something that you've got a problem with in your organisation, you're not sure how to take forward, I'm happy to talk about whether we've faced similar issues in our organisation and what our approach would be to those kind of things.
Okay.
But yeah, I mean, if there's specific questions around the data
No,
in your
thank you.
organisation, things like that, then obviously would encourage you to talk to those colleagues in your organisation. But I'm always open to some collaborative working and sharing of ideas and looking at common themes across organisations. So yeah, feel free to get in touch if you'd like to.
Thank you so much. Appreciate that.
No problem at all. Just having a quick look at some of those other ones. There's a few comments in there that some of those just about invites. There's a question around ICBs, whether they do something similar and across the system. I think that was raised earlier. So I know that within some healthcare systems, organisations are working much more closely together, and doing some kind of cross-organisation working and sharing of data. Leicester's a unique ICB in that UHL are the only acute provider, and Leicester Partnership Trust provide our community and mental health services. There's not a huge amount of overlap between us, so we've not really embarked on that journey yet. But I certainly know that other organisations have started to do some of that. So I think I'd encourage you again to go and have a chat with your finance teams within your ICBs and just try and find out about whether that kind of collaborative working has started or not. Just have a quick scroll. There's a question from Hannah just saying, was there a discussion on building stronger business cases for non-elective services such as UEC? Not specific to UEC, no. In my experience, a lot of the business cases that we've put forward for UEC in Leicester haven't used an awful lot of the Plex data, and those business cases are probably the reasons why we're showing deteriorations in productivity in UEC. A lot of those kind of things that we've put in to try and improve patient flow and get patients off the back of ambulances have all been done based on the patient care and not necessarily the impact on finance. So I'm probably not the best person to talk to about that one, I'm afraid. There's a question around how does this data link with operational costs related to estates and facilities? That's a good question. So we do allocate the cost of running our estates and our facilities services right down to a patient level. So we do that based on information that's available from those services. We look at how much space is occupied by certain services. We look about the types of patients that we have through and whether they'll be requiring catering, linen. Some of the costs are allocated as overheads, but we do push that down, and we have seen in some instances where our costs have increased across services because the costs of RE&F services have gone up by more than the rate of inflation. So the standard inflation rates that are applied to the NHS and that we use to do our modelling don't fully account for the massive rises that we've seen in things like costs of utilities. So we do flow those things through, and it has kind of given some explanations in terms of why we've seen deterioration in performances of our services. Christine, have you got a question for us?
Yeah, another question on efficiency, Steve, I'm afraid. So it's the pain
That's
of
okay.
the ops world, as you can imagine. So you mentioned those targets, which each trust have got. I've got one now. I'm sure most people are aware of it. I guess how realistic that is from the work they're doing. I mean, you mentioned about that's equivalent to an 1,800 nurses or 600 whole-time equivalent nurses. And we know for a fact that that simply isn't feasible. We just can't take the workforce out of it, really, isn't it? There are measures such as vacancy controls, etc., coming in, which is added pressure for us as ops. So I guess, is it realistic? If not, are there any sort of other solutions? This is probably a Keir Starmer, Rishi Sunak question rather than for you, Steve, but I'll ask anyway. Sometimes the answer is closer to where the delivery is, isn't it?
My honest answer, so if there's anybody else from UHL on the call, please close your ears. I personally can't see how we can achieve a £92 million cost improvement programme on a recurrent basis. I think we can make a really, really good stab at it.
Yeah.
When we look at the information that we produce, there are a lot of services that look to be significantly less productive than what they were previously. And the opportunities that we calculate probably indicate that we are around about that kind of value away from where we were pre-pandemic. So if we could get back to pre-pandemic levels of productivity, then yes, we could hit those targets. In reality, we've spent, or we've made decisions to invest a lot of money in our services that it would be very difficult to go back on and get back to the point that we were in 1920 without risking things like patient safety. And I think that's the real difficult thing. If we could go back and we could say, let's take those additional nurses off of that ward. Let's get rid of that extra unit that we've put outside of A&E to take patients off the back of ambulances. Then we could take out huge chunks of cash. But in reality, that's not going to happen. We also at Leicester, I think, have a huge potential opportunity because of clinical coding. I think we don't code all of our activity as well as we could. We are embarking on a number of projects to improve the quality of that clinical coding, which is going to be great for some of the elective services where we're still on PBR, but for our urgent and emergency care, we're on a block contract. So whilst my data might show that we receive less income in, say, that UEC pathway than what it costs, even if we change our coding, that income isn't going to grow. We might look better on the face of it from a PLIX perspective because we do it based on what you would have been paid under PBR, but in reality, our bottom line position is not going to improve because of that. So I think it's going to be a real stretch. We're fully invested in trying to meet that £92 million CIP programme, and we will be pushed to do so. But it's going to be really hard work.
Yeah. One follow-up question, if I may. Hopefully, it's a quick answer. Are you doing any form of capacity and demand exercise as a result, as an approach to look at that productivity at all, or?
I'm sure we probably are. I'm not very close to that, so I couldn't really.
Okay, no worries.
Go into too much detail on that.
Thank you.
That's all right, no problem. We've we've got another hand up. I'll just answer really quickly one other question that's in the slides. So in the chat. So somebody's asked whether PLIX is accessible in all trusts. PLIX is mandated by NHS for all acute organisations. I think it is for mental health and community, although it might not be as well developed in those services. So yes, it should be if you are an acute provider. Yeah, I'd encourage you to talk to your finance departments about that. Question from Joseph.
Hi. Sorry, I put quite a long one in the chat, and then realised it was probably easier for me just to have the conversation with you.
Okay.
So when you're benchmarking yourself against other trusts and you're looking at their procedures, how far are you able to drill down? So, for example, the one that I've given is when I worked in another trust in surgery, we did prostate surgery, and there were roughly two types. One was utilising a laser, and one was like scalpel surgery, basically. Then in my new trust, they don't have a laser, so they would be utilising scalpel surgery and a quote unquote robot assisted surgery. So the impact there will be that could be that there'll be a cost difference between how long those procedures, but then I'm conscious that you're comparing apples and oranges potentially, because it may be, say, £1 million outlay to get that laser in for the trust. If it's so, you kind of, it's about comparing the right things. Otherwise, I'm just conscious as a service manager, I would take that and I would say, right, okay, we're significantly more expensive doing this procedure than a comparative local trust, but actually, I'm working on erroneous information, if that makes sense.
Yep, sure. So this is where I might come unstuck a little bit. So we are required by NHSE to submit a certain number of fields in terms of what goes into patient care. Now, HRG is most definitely in there. There are a series of procedure and diagnosis codes that go in there as well. What I cannot remember off the top of my head is whether those procedure and diagnosis codes all flow through back into the outputs that are provided by NHSE. So I would say that if your finance team has got good relationships with other costing professionals, you would absolutely be able to get that level of data if it's in your clinical coding. I'm not sure whether it would be available in the national tool that you'd just be able to access and do without talking to anybody else. In all honesty, I can have a look and I can probably come back to you on that, but I don't know off the top of my head. But certainly it should be recorded at that level within those organisations' data.
Totally, yeah.
It's just whether it's reported back out nationally or not like that.
Okay, thank you.
No problem at all. Somebody else here says previous trusts that they worked in reviewed comorbidities and captured the data by going back through notes for patients. So we've had something at Leicester where we've tried to look at previous attendances for patients to pick up ongoing comorbidities, and I think we were told we weren't allowed to due to coding regulations, but that's something that's beyond my level of expertise. So I think there are certain tools that are out there that can do that for you, but it's certainly something that can help with the clinical coding, even if it's just prompting people to then go back and put it into the current set of notes. Somebody in there talks about the date of data collection on the model hospital. It does vary significantly depending on what the data is. So people probably do just need to be aware of that and conscious when they're having a look. Are there any questions that I've missed? Has anybody typed a question in and I've not answered. I've had a quick scroll through, but I think I got distracted by the wows and the workstations on wheels.
Steve, I think you captured everything.
Lovely.
Yeah.
Thanks very much. It's great to have so many people asking questions and wanting to know more. It's I think it is a really valuable resource to organisations, and hopefully you can go away and have a look at that locally and try to make some improvements on the back of it.
Thank you, Stephen. You would agree with me that this session has been wonderful. So I think this way we draw the curtain. Thank you, everyone. Bye-bye.
Yes, bye.